Good evening, Dr. Rose.
Good evening, sir.
Yes, good evening. Can you show your PPT?
Yes, sir. Sure.
Have you checked it?
Pardon, sir?
Have you checked your PPT, your presentation?
Yes, sir. I'm just checking it now.
Yes, please check in this webinar, in this
Yeah.
DIP platform.
Is it visible, sir?
Yes, it is visible. And please make it full screen. Yes, it is full screen.
Yes, sir. Full screen.
Can you move it further?
Move this one, sir. What should I move?
Yes, move second slide, third slide, so that we can see that
Okay.
it's moving or not.
Okay, now this seems to be stuck.
It's not moving.
It's not moving, sir. It was moving. Now it's moving.
Yeah, it's moving. Good evening, Arun sir.
Shall I stop
evening,
sharing,
Kaushik,
sir?
Yes, please stop. Dr. Kaushik sir, Dr. Arun sir, good evening and welcome.
Good evening, sir. Good evening, Kiran sir.
Yes. Please check your slides.
You're able to see the screen, sir?
Yes, able to see. So make it full screen. Yes, it is moving.
Thank you, sir.
Okay. Suresh sir, very good evening. Welcome, sir. Are you there?
Hello.
Yes, sir. Good evening, sir.
You can hear me?
Yes, sir. We can see as well as hear you, sir.
Clarity is all right.
Yes, sir. It's very good, sir.
Yeah. Okay, then excellent.
How are you, sir?
Oh yes, first class.
Okay, sir.
So
Thank you very much for giving you the time here for webinar, sir.
Yeah, sure. So all the participants have joined in now or about to join?
Yes, 2 participants have joined, sir. And Dr. Kalpana is yet to join.
Okay, good.
Dr. Paria is yet to join.
Okay.
She asked me for the link so that she is coming. So she will join within 2 minutes, sir.
Okay, good. So I think I will temporarily off the video. I just may. Oh my.
Yes, Kalpana madam has joined. So good evening, madam.
Hello, Dr. Makija, can you hear me?
Yes, madam.
Okay, so then just now I have a net. I'm lucky enough to join. I don't know how long
Yes,
it will
madam.
continue.
Please join for another 10 to 15 minutes so that we can start the program. After that, you can
2
go
minutes,
for
but
the,
for 8:30, it's 2 minutes to go.
yeah, 2 minutes only.
Uh,
Dr. Siddharth, can you check your slides?
Yes, I'll do that. I'm sure they'll work, but you never know. So,
bye-bye.
okay, share screen.
Okay, seen. Okay.
They're visible?
Yes. Good evening, Siddharth.
Yes.
How are you? Dr. Arur here.
Good evening,
Right,
sir.
sir.
How are you? How are
Oh,
you
yes.
doing, sir?
Yes, it is. Make it full. Make it full screen. Make it full screen.
Yeah.
Hi, hello. Good evening.
Good evening,
everyone.
all. Good evening, all. Good evening,
Krishna.
Kalpana.
Good evening.
Yes, my flight is delayed, so I could join.
Yeah, great. Good evening, all.
Sir,
Siddharth, Kiran, all the
Good evening,
faculty.
Sanjeev, sir. कैसे हैं आप?
good evening, sir. Good
Sir,
evening.
बढ़िया.
Welcome.
Thank you.
Yes, sir. It is normal working, and you can close your
कर दिया.
presentation.
Yes.
So, who will be the first speaker? Dr. Kiran?
Yes.
Mary, है ना, Dr. Mary?
Yes, sir. Ma'am.
Yeah, she
Yes.
will be the first speaker. Yeah.
Okay, Dr. Rosemary
Hello, good evening.
will be the first speaker, huh?
Good evening, sir. Good evening, all.
Yes,
Good
Dr.
evening.
Renu. Good evening.
Good evening.
Good evening, Dr. Renu.
So nice to see you all.
Can you present your presentation here, just to check it?
Right, I'll share my slides.
If I'll be out of the net, please excuse me, because very unstable at Puri. Net is not that strong.
So
No
we
problem.
have the backup of Dr. Sanjeev Joshi.
Yeah, I told him. Oh, yeah. I'm outgoing. Now he's incoming. President.
Sir, please see if my slides are running fine.
Yes,
Yeah,
yes,
it's okay.
yes.
Yeah.
Fine.
It's
It's
nice.
fine.
Nice.
Fine, no
Okay.
problem.
Okay, I'll stop sharing here.
Yes.
Right.
Hmm.
Okay.
Ma'am, you are just half away mark only. I am waiting for Dr. Paria.
Oh, he has not joined?
Is there?
Dr. Pradeep, have you joined?
Yes, sir. I've joined.
Okay.
Actually, some connectivity problem is there.
You are in
Okay.
Raiganj?
Hi, ma'am. Actually, I am in
Okay.
Raiganj now.
Same here. I'm in Puri airport and the connectivity is problem.
So should we start, ma'am?
I think we should. Already 8:31.
Yes. Only
Good
Dr.
evening, Arun sir.
is yet to join. Dr. Sanjeev sir, can you call Dr. Anup Verma to join?
Okay, I'll do that.
Yes, sir. So that I can start within time. So today is the 5th regular webinar of our AOPN. This is the DIP platform, and we have the regular first Tuesday 8:30 p.m. have the webinar for the PG students as well as for our practitioners, our pediatric practitioners, as well as for learning for the neurologist also. So today's topic is the ICU neurology, and we have the 4 eminent speakers on the different topics. So with this, I invite Dr. Kalpana Datta madam, who is at Puri airport. So she may have the connection problem. As early as possible, she can have the welcome talk. Ma'am,
Okay.
please.
Yeah. Thank you, Dr. Kiran. Very good evening to everyone, and I welcome all of you, all the all the speakers and the chairperson, Dr. Arul sir, and welcome all the delegates also in this AOPN Neurology Chapter academic activity we run in every month. The first Tuesday from 8 to 8:30 to 10:30. And I'll request all the viewers and the delegates, please encourage your postgraduate students to join, because it's a very interesting cases and all the experts are there. You can have all the queries fulfilled, and you can get a great learning will be there. So without any wasting much time, I request Pradeep Paria, who is a young budding neurologist. He has done his DM in pediatric neurology from PGI Chandigarh. Now he's posted as an assistant professor in Government Medical College in West Bengal. I'll request Pradeep Paria, you just moderate the session, request, call the chairperson and the first speaker.
Sorry to interrupt you, ma'am. And yes, we have the two eminent faculties, our dignitaries, Dr. Sanjeev Joshi, who is the president-elect of our AOPN, who is also present. I welcome Dr. Sanjeev Joshi, sir.
Yes,
in
Dr.
our
Thank you.
Welcome, Dr.
Thank you.
Sanjeev
And
Joshi also,
yes,
and Dr. Anup Barman sir also, I think, joined.
yes, Dr. Anup
Yes,
Verma
sir.
is yet to
Welcome
join.
you.
Am I
And
audible?
already joined, sir.
Yes,
So
yes,
I
sir.
Yes,
welcome
yes.
Dr. Anup Barman
Yes,
sir
yes.
and Dr. Joshi also, and of course, Dr. Jaishankar Kaushik has joined. Dr. Renu Shutar has joined. So I welcome all of you, and please
Yeah,
proceed with
yeah.
the procedure. I might exit from the
Okay,
network
okay,
because.
madam. Okay, madam. Carry on with your flight. And
Uh,
today's we have the our eminent faculties as the Dr. Arur sir, Dr. Suresh Rao Arur sir, who is the chairperson of today's program. So I am reading his biodata. It is not required though, but well-known faculty and well-known eminent dignitary of our AOPN. Since beginning, he is blessing us and encouraging us, all of us, to have the great journey of the AOPN. So presently, he is actually the pediatric neurologist and the director of the Parijma Neurodiagnostic and the Rehabilitation Center at the Bangalore and Mangalore. And his major achievement is he is the first to start the Department of Pediatric Neurology in the country itself at NIMHANS, Bangalore in 1981, way back at 1981. And he is the recipient of the award, the International Who in Medicine, awarded by the International Biographical Center, Cambridge, England in 1995, and is the recipient of the award 500 Leaders of the Influence in the 20th Century Achievement Award from the America itself, the American Biographical Institute in 1997. He is the Lifetime Achievement Award awarded with the Lifetime Achievement Award in 2017 by the IIP Karnataka State Chapter. And he is also awarded with the Diploma of the Fellowship FRCP Glasgow in distinction as the physician by the Royal College of the Physician and the Surgeon in 2018. And he has the oration in his name, Dr. T.S. Malesh, late Dr. E.S. Bovaki, Dr. Aladi Venkatesh oration in 2012, 2015, and 2019, respectively. He is the exclusive pediatric neurologist practicing since 1981 and faculty at NIMHANS for 12 years. And he was the HOD, Department of Neurology in Manipal Hospital for 10 years. He is the treasurer and the later the secretary of the Neurology Chapter IIP, which we are belonging in 1987 and 89. He was the president IIP BPS for 2 years in 1988 and 1990. He was the treasurer IIP Karnataka Stage Branch in 1991. He was the president IIP Neurology Karnataka Chapter from 2015 to 2018. And he was also the president of the International Child Neurology Association. So with this, I welcome Dr. Suresh Aru sir for the presentation for our this as a chairperson of our talk of our session. So moving
Thank
to
you,
the,
Kiran.
yes, thank you very much, sir. And moving to the next for this, Dr. Suresh Aru, sir, I welcome him. I invite him for the blessings, sir.
Thank you. I think it's good evening. Great to be here on this occasion. And I think the topics selected are very appropriate, which are, the day-to-day problem that we see in pediatric neurology. And I'm glad that we have a galaxy of good speakers. I'm sure we'll have a good discussion on this. And in this note, I should also compliment the association for regularly conducting these programs. Because I remember when we started this association way back in '86, we had problem getting the audience. But in the last 3-4 decades, it has grown to such an extent that it has become one of the most popular subspecialties of pediatric neurology. So I'm very glad that we have an august audience and good speakers. So with that, I welcome and to start the program.
Thank you very much, sir. And now I invite our moderator, Dr. Paria, Dr. Pradeep Paria, for conducting the session.
Thank you, sir. Good evening to all of you. Special thanks to our chairperson of AOPN, Professor Kalpana Datto, Secretary Sir Dr. Kiran Makhija sir, today's chairperson Dr. Arud, today's guest of honor Dr. Anup Verma and Dr. Sanjeev Joshi sir. I want to go to first speaker. Our first topic is neurological assessment and approach in ICU setup. That our theme was the ICU neurology. Our first speaker is Rosemary Lawrence. She is a consultant, pediatric neurologist and intensivist of Cosmopolitan Hospital, Thiruvananthapuram. She had done her MD and DNB in pediatrics and also done the PG diploma in developmental neurology and 2 fellowship from IIP in pediatric critical care and pediatric neurology. Her area of special interest is intensive care and epilepsy. Rosemary Lawrence, ma'am.
Thank you, sir, for the kind words.
Are you there?
Yes. Can you hear me?
Yes.
Yes, ma'am.
Okay. Thank you, sir, for the kind introduction. I thank AOPN for giving me this opportunity for presenting in front of this audience. Without wasting any more time, I would like to go ahead with my presentation. I hope this is visible.
Yes, visible.
Okay, very good evening to you all. So my topic today is neurological assessment approach in the PICU. So as you all know, neurological disorders and direct brain injuries are a reason for at least 11 to 16% of admissions to the PICU. So, and other than that, there are many critically ill children who are at a higher risk of brain injury and neurodevelopment difficulties like in patients with complex heart disease and premature birth. So over the years, the survival has improved because of better intensive care. So there is reduced morbidity. So our target now is to reduce morbidities and to optimize quality of life for survivors. And so for that, assessment, monitoring, and protection of the brain is of paramount importance. Yeah. So the objectives for today's talk, we will be first identifying the patient types at risk for brain injury, and then we'll go through some of the assessment tools and the clinical evaluation, and then we'll discuss some evidence regarding cranial imaging, invasive and non-invasive monitoring, and we'll be ending with approaches for neurodevelopment follow-up. So what are the patient groups at risk? So there is a primary neurological disease patient group, which is severe traumatic brain injury, neuroinfection or inflammations, status epilepticus, stroke, hypoxic ischemic brain. They constitute of about 16.2% of the ICU admissions. Then there are secondary mechanisms of injury to the brain, secondary to systemic conditions like severe sepsis that comes up to around 2.8%. And there's another group of PICU population, which is that of cardiac disease, especially after cardiac surgery, where they have an increased risk of brain injury. So there are many conditions related to that. That is, probably there are underlying genetic abnormalities of the cerebral structures along with the cardiac problems. And there is a cardiopulmonary bypass, which can cause hypoxic injury. And again, perioperative period, there can be low cardiac output states, which may affect the brain perfusion. So what are the challenges in examination in a PICU? As you all know, it is a very challenging thing to examine these children. They may present with altered mental status, agitation, pain, and sedation will be there to control the pain. We use neuromuscular blockade for easing the mechanical ventilation. And then there are other conditions like hypothermia, metabolic disturbances, which can affect the examination. Then, of course, in a child who's ventilated itself becomes a challenge to examine. And there can be other surgical or traumatic lesions to the extremities, which can alter the neurological assessment in the PICU. So what is the general approach? So as always, for neurological assessment, we go by history, general examination. But in this situation, more emphasis given to the level of consciousness, and neural and serial examinations are very important to see how the child is progressing. So history, as you all know, we go for detailed history from all, wherever it is possible, from the patient, the family, friends, and witnesses. We assess the acuteness of the event, the duration of the symptoms. We look for etiology, whether it is a primarily neurological problem or a secondary problem. Then was there another similar history in members? And a history of current infection symptoms and infectious exposures is important to differentiate between infective cause and autoimmune causes. It can help in differentiating. Trauma is a very common presentation for abnormal neurological injury. So it can be accidental or non-accidental. So that has to be considered. So the history may sometimes be difficult to be achieved here. And of course, associated past medical history, any history of seizures or any other developmental delay, all those are important. And what all medications the child is on, and if there is a possibility of toxic ingestions. Vital examination, as always, they give some clues. Heart rates, bradycardia, tachycardia, both have their own significance. Bradycardia and raised ICP, tachycardia and sepsis, intracranial hemorrhages, and drug poisonings. Blood pressure in hypotension shows as hypotension or hypertension. Hypotension can be in a scenario of sepsis or drug overdose, whereas hypertension is classically described in Cushing's reflex in raised ICP, and also in hypertensive encephalopathy and certain drugs like Keto and benzyclidine. Temperature variations also can be prominent in such patients. Hypothermia also will give some clue to the etiology. Like sepsis, subarachnoid hemorrhage, hypothalamic injury, salivary poisoning, all may present with hypothermia, while sepsis, hypoglycemia, hypothyroidism, environmental exposure, etc., can present with hypothermia. Head-to-foot examination also can give some clues, like pallor can point towards cerebral malaria or intracranial bleed, icterus in hepatic encephalopathy, rashes in many viral diseases, rickettsial diseases, petechiae in dengue, meningococcemia, etc., and hematomas in trauma or non-accidental injury, and dysmorphism, neurocutaneous markers may suggest a possibility of associated seizure disorder and abnormal odors in diabetic ketoacidosis and hepatic coma. So our main then after the general assessment, we then move on to the focused neurological examination. The focus here will be more on level of consciousness, pupillary size and reaction, motor power in the limbs, involuntary movements, and brainstem reflexes. Now, based on the level of consciousness, we get three types of patient groups. One is the conscious patient. Here, it's relatively easier. We can go with the traditional neurological examination, including cognition, cranial nerves, motor and sensory functions, reflexes, and coordination. But however, to identify the etiology, we can adapt the examine to find the underlying neurological process. And then we have to go with serial examinations to see whether the patient is improving or worsening. And then the second group of patient is the sedated patient. That is a major confounding factor in the neurological assessment. So as far as possible, we should assess the feasibility of interrupting the sedation. So interruption of continuous sedation is recommended, and it has been shown to reduce the amount of time spent in the ICU. The only exception where it is not tried is when there is raised ICP, so where the ICP can be affected badly if you remove the sedation. So the sedation interruption helps us in scoring the delirium, the level of the coma, or if there is the grading of the muscle strength using various scales can be done. Then there is another group, which is the delirious patient. So as you all know, delirium is a behavioral syndrome which has acute and fluctuating change in mental status, and it could be due to underlying infection and illness or the treatment side effects, or it could be due to a disruptive PICU environment. So it is secondary to a depression in overall brain functioning or bilateral involvement of the limbic structures. So if the importance of detecting delirium early is that if it goes undetected, it has been shown to have poorer PICU outcomes. So there are many tools which help us in the assessment of delirium. This is a commonly used one, PCAM ICU, the pediatric confusion assessment method. Here we look for the two major features, that is the acute change of fluctuating course of the mental status and the inattention, and a minor feature, which is the level of consciousness. So there is the content of consciousness and the level of consciousness. Content is more important. So if all three of these are present, then there is a delirium. If the initial two are not present, then delirium is considered to be absent. And there are two different scales available. One is the pediatric PCAM, the other is PSCAM for preschool children, which is validated for less than 5 years of age. This is another tool that is used. So for observation withdrawal symptoms, pediatric delirium. This gives a maximum score of withdrawal of 15 and delirium score of 16. This also can be used. Now, the last group of patients which is commonly encountered is the comatose patient. Here, we have to assess the level of arousal. Then we have to, how we adapt the examination here is in this way. We go for the level of arousal, brainstem function, motor responses, and the respiratory pattern are given more emphasis. But initial stabilization is of paramount importance. The assessment should not interfere with the basic life-saving resuscitation things. So that has to be kept in mind. And there are various assessment tools which are also used here. So initial stabilization, as you all know, we have to maintain patent airway. Hypoxia and hypoventilation can definitely lead to worsening neurological statuses. We have to prevent aspiration and maintain circulation. Again, hypotension can assess the neurological status. So IV access blood pressure measurement has to be done. Along with drawing blood for analysis and cultures, make sure that the cervical spine is cleared, because assessment without that can further damage the cervical spine. So that should be kept in mind. And if infection is suspected, empirical treatment should be added. And in case of raised ICP, assessment again should wait before stabilization. After stabilization, so you can elevate the head of the bed to 30 degree, and in case of raised ICP, and flatten it in cases of posterior circulation stroke. So seizure control as and when needed, hypoglycemia treated as and when needed, and body temperature, electrolyte imbalances all should be monitored. And antidotes, if a drug dose is suspected, can be given. Routinely, it is not given, as supportive care has been demonstrated to be superior than giving antidotes. So here are the commonly used scales. As you all know, ABPO scale, it is a very primitive scale, but it is very useful, easily administered, so can help us in quick assessment. It correlates quite well with the Glasgow Coma Scale ranges. So alert is corresponding when the patient is awake. and it corresponds to a GCS score of 50. And verbal patient responding to verbal stimuli is corresponding to 12 to 13, and a physical response is corresponding to 5 to 6, while a GCS of 3 is that of unresponsive. You're all familiar with the GCS scaling, which is different for both child and infant, with the main changes in the motor response. And the only drawback is that there is no provision for using it in, it's not very accurate in intubated patients. So 4 score deals with that. It can be used in patients who are intubated also. So here we have other than the speech is replaced with brainstem reflexes and respiration, and score is given for each component. This is a relatively latest assessment tool, serial neurological assessment in pediatrics, also called SNAP. It is considered to be considered to have a near perfect inter-rater reliability. It assesses the neurological function in 4 components: the mental status, the cranial nerves, communication, and motor function. There are 3 scales which are validated in age groups of more than 2 years, 2 to 6 months, and less than 6 months. The only limitation is that it's a relatively new tool, so there are limited validation studies, and there's no validation outside of the pediatric ICU. And it is also a little longer, more cumbersome to administer than GCS, which is relatively faster to administer. But the advantage is that you can score a child who is intubated, sedated, or has had developmental disabilities. So the assessment, there are some practical aspects that we have to consider. Many a times we have to observe spontaneous eye movement, opening, verbalization, and motor activity has to be noted. Then once spontaneous activity is noticed, then we move on to, if that is absent, then we move on to call. If that child is not responding to that, we move on to shout. And then even then, if the child is not responding, we move on to pain, each with increasing intensity. So coming to the pain that is applied, there are 2 types of pain: the central pain, where you give a sternal, pain in the sternal region, and the supraorbital notch pressure. This is mostly used for motor movement. Peripheral pain is used for eye movements, eye assessment, because it can elicit a spinal reflex, which causes a flexion of the testicle, which actually is a reflex, and it does not indicate intact brain function. So, while assessing the movement of the limbs, you can see if there is any reduced movement that can indicate stroke. So this is how this is assessed. Localizing of the pain, the patient localizes it. Then withdrawal to pain, patient withdraws away from the pain. And this is the abnormal flexion to pain, and this is the abnormal extension to pain, which is all given the response score. Now, the value of this is localization. As you all know, the consciousness is maintained by the reticular activating system. So it is a multi-connected network between the cerebral cortex, thalamus, reticular formulation, and sensory pathways. So it has a very low localizing value, because there is no specific region which can which initiates or maintains arousal. So the lesion has to be sufficiently large to cause an impairment of the consciousness. So technically, the degree of impairment is proportional to the size of the cerebral lesion, and bears very little relation to what area of the cortex was involved. So next important assessment is a pupillary assessment. As you all know, we have to look at the position of the pupil. It can be noticed by lifting the patient's eyelids, and then you have to see whether the pupil is central, deviated, or disconjugate. And then we have to assess the shape also, shape and position. So pupillary response is to the reaction to the flash of light. And these are the localizing values it has. You have a normal reaction in awake, where you have a constriction with light. In diencephalic relation, you get small reactive pupils. In midbrain, you get mid-position unreactive pupils with spontaneous flippers. And midbrain tegmentum, you get mid-position, irregular, unreactive, non-centered pupils. And peripheral third nerve palsy, if it is ipsilateral, it will be large and unresponsive to light. And pons will have a lesion at pons will have a pinpoint responsive pupil. So usually unequal pupils suggest a structural lesion, whereas symmetric pupils can be structural or it can be toxic or metabolic. Now coming to ocular movements, you have to examine the spontaneous and reflex eye movements. Each has its importance. Like conjugate, if there is a conjugate deviation, you can see that when the frontal lobe is involved, the eyes will look towards the site of the lesion, as the action of the frontal lobe is to push or look look opposite the site of lesion. So if there is any lesion causing reduced, affecting the frontal lobe, the eyes will look towards the site of lesion. And the same, but the case is opposite for medial thalamus pons and seizures. Eyes will look away from the site of lesion. And thalamus midbrain pretectum or metabolic causes will cause downward deviation. Brain stems and sleep will have upward deviation. In a cranial of third nerve palsy, you will have a down and out eye with the pupil dilated, whereas lateral lectus palsy, cranial of fourth palsy, will have a eye inwardly deviated. Posterior fossa will have a skew deviation and vertical displacement. So spontaneous movements of the eye also can be noticed. And if there is a horizontal divergence, it can be commonly seen in drowsiness, and a slow to and fro horizontal movement can be seen in bihemispheric dysfunction. So when you're not able to elicit spontaneous movements, Doll's-eye maneuver and a cold cannula test can help us in seeing the movement of the eye also in the unconscious patient. So these are the inferences of the spontaneous eye movements. If there are purposeful movements, then it can be locked-in syndrome, catatonia, or pseudocoma. If there are roving eye movements, it can be non-specific bilateral hemisphere injuries. And if there is nystagmus, if there is refracted nystagmus, it means mesencephalic tegmental lesions, and convergent nystagmus mesencephalic lesions. And nystagmoid jerking of a single eye is seen in mid-pontine to lower pontine damage. Ocular corbing, which is actually a rapid downward, conjugate downward movement with slow recovery to mid-position, is typically seen in acute pontine lesions. So eyelids and the corneal reflex. So here we have to observe the position of the eyelids, and whether the impaired, if the patient is impaired consciousness is impaired, the eyes will be closed, and we can lift these eyes and release. A normal response will be gradual return to baseline, but if there is an ipsilateral facial nerve dysfunction, there will be failure to close and come back to the baseline. You can also observe the blinking. If there are spontaneous blinking, that means that the pontine reticular formation is intact. And if there is unilateral abscess, that means there is ipsilateral facial nerve dysfunction. And if there is complete abscess, then the reticular formation is affected. Then corneal reflex assessment, touching the edge of the eye with the contact bisque. If there is eyelid closure, that means there is an intact facial nerve and seventh nucleus. If there is Bell's phenomenon, that is the upward deviation of the eyes is noticed with the inadequately closed eyelid. That means that the brainstem pathways between cranial of third nucleus and seventh nucleus are intact, and the injury is at the seventh nucleus or the facial nerve. And contralateral jaw move deviation can be seen in trigeminal nucleus above midpons, but here the Bell's phenomenon will be absent. As we mentioned before, oculocephalic reflex can help us in assessing the movements of the eyes in the unconscious patient, and it also gives us information whether the brainstem is intact or not. So the head is briskly moved from side to side, and a positive response is where the eyes rotate to the side direction opposite to the side of the movement, and that indicates that the brainstem is in fact intact. And the same can be done for upward and downward movements also, where there is you can see a downward deviation of the eyes during extension and an upward deviation during flexion. So that also can be done. Usually the eyes should gradually return to mid position in a smooth conjugate movement if the brainstem is intact. Similarly, oculovascular reflex is also used to assess the brainstem. Here the head is elevated at 30 degrees so that the lateral semicircular canal becomes vertical and that generates maximal response. You have to make sure that the tympanum is intact, the external ear canal is clear, and C-spine is clear, because there will be, sorry, C-spine clearance is not necessary here. It's more important in the oculocephalic reflex. So here, even with the space-spine problem, we can check it. So there is introduced, ice water is introduced, and we look for ocular division, around 100 ml of water can be instituted. We look for the movement of the eye. So in case of when the consciousness is lost, the fast component becomes lost. And so the slow component deviates the eye in the direction of the irrigated ear. As you can see here, cold eye is cold stimulation is being in this ear and the eye is getting deviated on this side. And the same here. A warm water will have a opposite effect. So the final reflex, brainstem reflex that we check is the pharyngeal or gag reflex and the cough reflex. So in an intubated patient, in a non-intubated patient, so it's easy, the classical way of touching the posterior pharynx and looking for the movement of the palate. But in intubated patients, it's quite difficult. You might you can try jiggling the ET tube back and forth and then look for the response. So, but generally an intubated patient can have a suppressed response as it is. Then tracheal cough reflex, it can be done in an intubated patient where you can advance the suctioning catheter below the ET tube down to the level of the carina, and that will elicit a cough reflex if the medulla is intact. Another important part of the examination that gives us clue in localization is the breathing patterns. As you all know, chain stroke, it has a hyperapneic phase followed by an apneic phase. It's usually seen in large bilateral hemispheric lesions, and central neurologic hyperventilation, where you can see sustained, regular, rapid, fairly deep hypopnea, which is usually seen in lower midbrain pons. Then some systematic conditions, hypoxia, and bilateral metabolic acidosis, etc. In apneustic breathing, you get an inspiratory pause and an expiratory pause. They keep alternating. It is usually seen in mid or low pons lesions and has a poor prognosis. Cluster breathing is seen with clusters of breath separated by irregular pauses, which is indicative of low pons and medulla lesion. And ataxic breathing is completely irregular deep breaths and shallow breaths, which is localization to medulla and which is also very poor prognosis. So motor response, we can see the abnormal posturing, or we can see the movement of the motor response. The abnormal posture indicates can be of two types, the decorticate type and the decerebrate type. Decorticate is where there is abnormal flexion of the upper limb. It has a relatively better prognosis than decerebrate posturing because it has a higher, it is at a higher level, at the dying Teflon level. And so the damage there will be less. Whereas decerebrate is when the compression of the brain is at the level of the midbrain. So it's a very tight area, and compression there will cause more disastrous results. So this is how you can help localizing into cortex and brainstem. We discussed most of these points. There are spontaneous eye movements, upward and downward eye movements, and it's more likely to be cortical. Brainstem, anisocoria, mid-position fixed pupil, ocular bobbing, skew deviation, internuclear ophthalmoplegia, all can localize to brainstem. Now, a few words on motor weakness. It becomes important in if there is a associated motor weakness prior to the ICU illness. Assessment is very important to get the correct etiology, like it could be a polyneuropathy or a myopathy. So like polyneuropathy, like Guillain-Barré. So all those, or it could be a cortical lesion or cranial cortical lesion. So all these, for the etiological diagnosis, a detailed motor muscle power evaluation also becomes important. So as far as possible, all the components of the examination should be properly done. And special care should be given to see the symmetry in every aspect of the exam, and to see whether facial and extraocular muscles are involved, proximal or distal are involved, respiratory muscles are involved, and all the other components of the examination should be checked. Any other motor signs like fasciculation, fatigability, myalgia can add to the diagnosis. Now, this is another common entity that we see in ICUs, ICU acquired weakness. How it separates from other entities is that the upper motor neuron signs will be absent and the facial and extraocular muscles will be spared. Weakness is usually symmetric and diffuse and does not fluctuate or progress in ascending or descending patterns. It can be explained by critical illness, polyneuropathy or myopathy. And these are some of the things that you have to keep in mind. Abdominal movements, seizures can be very commonly seen. Tonic-clonic or stereotype movements can be present. These are easy to diagnose and treat, but there can be very subtle recurrent and continual focal motor activity or presence of nystagmus or change in pupillary size, which may point towards possibility of non-convulsive status. So EEG becomes must here. Then you have to look for myoclonic jerks, which can present in anoxic and hepatic encephalopathies, and dystonias will point towards extrapyramidal involvement, which can be seen in Japanese B encephalitis, tubercular meningitis, inborn errors of metabolism, etc. So with some basic investigations are required. We have to go through all the CBCs, electrolytes, thyroid function, and all the regular investigations that we do. Now, coming to the next important part, which is the pediatric neurocritical care monitoring. There are various modalities, the commonly used ones are the neuroimaging. We can use portable ultrasound, especially in children with the open AF. Here it is very useful for a critical sick child to rule out hemorrhage, especially in conditions where ECMO is being considered. So in newborns, it's very useful. And early CT is also another modality that can be used. There are many indices available based on gray white matter attenuation ratio, which has good sensitivity in picking early hypoxia. So, but the relevance here is to use it serially, and that's when it gives us important information. The best modality of imaging is, of course, the MRI brain. It is especially better in neonates, as the neonate is an unmyelinated brain, and so gray white matter attenuation becomes difficult there. And the diffusion weighted sequences have the advantage of detecting ischemia by 1 day to 5 days. And in neonatal HIE, MRS can pick it up within 24 hours. So non-invasive neuromonitoring methods commonly used is the EEG. It helps us in detecting the seizures and prognosticating hypoxic brain insult also. And the problem is it may not be available everywhere, and the technical difficulties may be present. A much higher level advanced method of monitoring is the near infrared spectroscopy. It is usually used in cardiac units, especially post-operative. So where they look for regional cerebral tissue oxygenation, and they look for decline in the tissue oxygenation, and any decline noticed as 20% decline from baseline or less than 50 or 40% indicates that there is a low cardiac output state, and you have to institute measures to improve the cardiac output. Then transcranial ultrasound, it helps us. It's another form of non-invasive monitoring, where we can assess for vasospasm, the blood circulation, the loss of cerebral auto-regulation also can be detected in this. It's a surrogate, but the problem here is operator variability is very high. It needs a level of skill to get the temporal window and see the doctor effectively. And then there is automated pupillometry, which is surrogate for assessing the raised ICP. What studies have shown is that a reduced rate of construction or dilation is usually correlates with a high ICP. So that it helps in assessing the raised ICP. But again, there is limited data on this. Then the optic nerve sheath diameter assessment, more than 5 mm is an indicator of raised intracranial pressures. Here also the data is limited. Invasive monitoring, we know for sure ICP monitoring, especially in severe DBI, data has proven that it has helps us in better survival, especially the CPP pathway. So the most commonly used is the intraparenchymal catheter via bolt, and the target is to keep the ICP less than 20 or keep a cerebral perfusion pressure of 40 to 50 millimeters of mercury. It has demonstrated to have a better hospital survival. Non-traumatic raised ICP, the data is limited, but there is studies that it can be useful. More studies are needed. Then there is partial pressure of brain tissue oxygen monitoring. So here, this is mainly used in a setting where the, hyperventilation is being used for raised ICP. So any value less than 10 mm means that there is ischemia happening, and that has to be corrected. So coming to the last part of the presentation, here we have the post-intensive care syndrome in pediatrics. So this is what happens after an ICU stay, how the ICU stay and the morbidities that is acquired during the ICU stay or before due to the illness can lead to neurological sequelae in a child. So this is actually a multi-component are there. So the child, not only the child, the family, the parents, siblings are affected, and of the physical, cognitive, emotional, and social health of all these are affected. So this entity shines the light on that, and it helps us in addressing all those factors. And the challenge, so next is the neurodevelopment follow-up, which is also important. Once the patient is out of ICU, we need to make sure that the brain development is following the proper track. So the question rises as to whom to follow. So that many factors can be considered, like how the pre-existing factors of the child was, how many comorbidities were there, was the child young, is there a poor socio-economic status. Then management during and characteristics of the PICU admission, how severe the illness was there mechanical ventilation, long mechanical ventilation, ECMO or delirium, all those things are taken into account. And the recovery phase, how was that? Was there a high level of stress and anxiety in the children? What were the coping strategies of the family? All these are considered. Again, there are many challenges in developing a follow-up plan, because there is a marked heterogeneity. It's a wide variation, range of diseases and age group of children. So standardizing the outcome becomes challenging. And mainly the inputs we get us from the parents. So sometimes the assessment is not correct because the parental perception may be subjected to parental well-being. And it requires extensive collaboration between research and clinical setup. So with this, I come to the end. Thank you for your time and attention. Shall I stop, sir?
Yes, stop sharing. And Dr. Arur sir, can you please some comment and give insight into the topic?
I think it was a wonderful presentation because she has covered through all the aspects, and especially she has highlighted on the importance of various neurological signs, starting from level of consciousness, pupil, ocular movements, and cranial examination in helping in making a clinical diagnosis. But only I think I would like to ask you, among the scales that are available, which one do you think is highly recommended?
So
For the
currently
serial-
the data is showing SNAP is currently recommended, sir, because it has a higher inter-rater reliability. So it seems that the assessment is more objective when we use this.
Are there any studies which have compared between the ABPV and SNAP?
Yes, yes, they have compared with GCS, sir, and it has come out to be better, definitely better in the studies. But there are not many studies, there are very few studies, sir. It is just developing, but it has been consistently showing good results.
Another this thing I would like to ask is the use of continuous EEG monitoring in ICU patient who are critical.
Yes, sir. What studies are showing is that it is reducing the seizure burden for sure. Continuous EEG monitoring. Once we address the seizures, the seizure burden is reducing, but studies have not been able to demonstrate effect in the outcome. There has been no significant difference between the outcome of a child who was monitored with continuous EEG monitoring versus a child who was monitored by clinical seizures. So the outcome was relatively same, but the seizure burden was definitely less in a child who was continuously EEG monitored.
From the perspective of postgraduates, I think it's important is not a single evaluation. It is a serial evaluation that gives you a correct information whether the child is improving or deteriorating. Especially if you take all the signs like the level of sensorium, pupil, ocular movements, then gag reflexes, and the pattern of respiration, you will be able to make out. And other important thing is the history. You should be able to take the onset of illness and the progression and relapse and recurrences. Previous history is also equally important before they get admitted, whether it was an acute onset or they had a neurological problem prior to the onset of the current illness. So I think otherwise, I think she has covered quite extensively on the assessment. So if anybody wants to make a comment, they are most welcome.
Hello.
Yes,
Dr. Mary
Yes,
ma'am,
you-
actually in ICU, usually we go for the GCA score or rather 4 score
Yes.
also.
Yes,
That
yes.
is replaced by brainstem reflex and respiration.
Yes.
Is there any comparative study between GCS and 4 score? There is GCS score for pediatric populations also, but is there any comparative score for GCS or 4 score?
I did not come across that actually. I was assessing more of SNAP actually. But from the studies that I went through, they have said that both of them have lesser inter-rater reliability. So the assessment, like serial assessment, becomes less objective. So each rater might rate differently. The objectiveness becomes less in both the GCS and 4 scores.
Okay.
So that's why both of them are not that adequate.
Actually, okay, ma'am. Is there any guideline or any criteria when to reevaluate? Sir has already told that you have to go for the reevaluation of the baby. Is there any score or is there any guideline when to reevaluate according to GCS or 4 score?
Worsening scores, we have to, there's no particular guideline as such. What they have asked is that worsening scores should prompt immediate investigation and management should be replanned immediately. We have to be very, the monitoring has to be intensive. Any change, any decline should be addressed immediately. Only then can we prevent further brain injury. So that has to be monitored religiously.
Okay. Ma'am,
Yes.
one another question is there how to score motor wise in hemiparetic patient? I just asked about the GCS score.
Hemiparetic patient. Okay, okay. You can use the the non-paralytic side in that case. Because if there is a asymmetry, we can base the score on the non-paralytic side. For level of consciousness, yes.
Okay, ma'am.
Because it's a reticular activating system, no? So that is what we are assessing. The stroke is due to some other lesion in the cortex. So whether we want to see if the reticular activating system is okay. So the non-paralytic side can give us that clue.
Okay.
Yes, Dr. Pradeep, we have to take care of the time also. We have to stick to the 25 to 30 minutes for a speaker. So please invite
Okay,
the
ma'am.
next speaker, and every speaker has to be take care of that time also.
Thank you, sir. Thank you, ma'am, for your elaborate presentation. Our next speaker is Renu, ma'am, Renu Shuthar. She is now associate professor in pediatric neurology department in PGIMER Chandigarh. She had done MD and DM in pediatric neurology from PGIMER only. They now is executive board member of the AOCN for 2023 to 25. She had more than 160 publications in national and international journal, and she also recipient of the CPCH visiting fellow in 2019. Her area of interest is CNS infection, stroke, and neuromuscular disorder. Renu, ma'am, for your talk over status.
Thank you, Pradeep, for the introduction. I'm audible. I hope I'm audible.
Yes, yes.
Yeah. So I thank AOPN, Kiran sir and Kalpana madam for inviting me for this session. So I think it's practically covering all aspects of pediatric neurology in ICU. So with that, I'll start my presentation on status epilepticus. So yeah. My slides are visible?
Yes, ma'am.
Okay. Okay, so I'll try to stick to the time given to me. Status epilepticus is the most common medical emergency in child neurology. It's a quite common also. And if we see the statistics around in developed country, about 1/3 children do not respond to the first line anti-epileptic, and the numbers are very high in low middle income groups because of different etiology, different in the presentation of the child to the referral centers, delayed in seeking treatment, and about 20 to 25% of patients progress to refractory and super refractory status epilepticus. And the mortality is very high, and survivors suffer from severe neurological disability. So it's important that we know the basics of status epilepticus diagnosis and management. So in this presentation, basically, I will take a case and discuss along the case that how should the management should be done or should be proceeds with some role of EEG and MRI and diagnostic evaluation and treatment, evidence-based treatment. So I'll start with the case that is typical. That's how these patients present to us. 6-year-old child, normal, low-grade fever for 3 days, which has subsided, and he was sleepy during those 3 days, but was walking and talking, eating properly. On day 5 in the morning, when he went to school, had a seizure, which was noticed by the parents as a tonic posturing, and he has loss of consciousness. No trauma. Immediately taken to the local pediatrician, where he saw that child has a generalized tonic-clonic seizures, which was lasting for more than 5 minutes. So he received first dose of lorazepam. However, seizures were persisting, which was parents has told that his left side of face and arm was twitching and he was not responsive. So this is a scenario. So we should understand that this is a typical scenario, and this is how these cases has to be evaluated and managed. So definitely this child is in status epilepticus because when he reached to the pediatrician, he was seizing and seizures was more than 5 minutes and he was unconscious. So how do we define a status epilepticus? Basically, so definition is given that a seizure which persists for more than 5 minutes or a child who present convulsing to a healthcare facility without regain of consciousness in between. And this is basically because of the failure of mechanisms which are responsible for seizure termination in the neurons and brains. And the dictum is that longer a seizure is lasting, is less likely is to be responsive to the medication. So we have a concept of T1 and T2, which is given by ILE. So T1 is the time when the seizure starts, and if it is not treated within the T1 time, it's unlikely to respond. And it's associated with long-term consequences and neurological damage. After if seizure progress to T2 time, then it's unlikely that they are going to respond and there is a permanent neurological damage. For a generalized tonic-clonic seizure, the T1 is 5 minutes, that the treatment should start within 5 minutes. And if it is progresses more than 30 minutes, then it is not likely to be response and associated with neurological sequelae. For a focal status, T1 time is 10 minutes and T2 time is 60 minutes. And for an abscesses, T1 is 10 to 15 minutes and the T2 is not known for abscesses basically. So this table summarizes that for tonic-clonic movement seizure, 5 minutes treatment should be started. And if it progresses more than 30 minutes, then you have consequences long-term. And for focal, it is 60 minutes and abscesses, it is not known. How this 5 minutes and 30 minutes has come, that I'll explain in my next slides based on these animal studies basically. So what happens in a convulsive status epilepticus, there is an excessive energy demand because of ongoing neuronal activity, which leads to cardiorespiratory, the blood circulation is diverted towards brain. There is a peripheral hypoxia. It leads to hypoglycemia, hyperthermia, and cardiorespiratory instability. So in the animal models, what has been noticed that within first 20 to 40 minutes, there is a kind of a response in the body, which leads to increased cerebral blood flow, peripheral vasoconstrictions, and anaerobic metabolism, which if remain uncontrolled, leads to organ dysfunction. And by 30 minutes, there is a failure of compensatory mechanism and leads to neuronal death. And these are the receptors, which are like neuron, GABA receptors present on the neuron. These are responsible for maintaining neuronal stability. Once these are like disturbed, there is an excitatory state. So what has been seen in animal models that a prolonged convulsion leads to lesions in the cortex, cerebellum, hippocampus, and the pattern which is very similar to seen after the animal model has suffered from a cardiac arrest or severe systemic hypotension or hypoglycemia. So we should understand by like if you have a 30 minutes of convulsive seizures, the changes could be very, very severe and can lead to severe consequences. So the pathogenesis is that once the seizure starts, what happens in the neuron, the GABA receptors, they tend to internalize, like they are not present on the surface. So a drug like benzodiazepine, which acts on these GABA receptor, is less likely to act. And in place of GABA, the NMDA receptor, which usually do not present on the surface, comes to the surface of neurons, and these are excitatory, NMDA and AMPA. And so there is a loss of neuronal excitation, and which leads to uncontrolled seizures. So the treatment, so by 5 minutes, if like benzodiazepines are given, they can respond. But if it is prolonged, then benzodiazepine working on GABA receptors, usually these GABA receptors do not like stay on the surface, so the seizures become unresponsive to benzodiazepines. So the convulsive status epilepticus is divided into 4 parts. The first one is the early phase, and second is established. So the timeline is also given for convulsive status epilepticus. So it is the stage 1 within 5 to 10 minutes, and stage 2 lasts for up to 30 minutes, and stage 3 is 30 to 60 minutes, and 4 is after more than 24 hours. So a very important aspect of management is pre-hospital care of child with the status epilepticus, because we should know that time is brain. As soon as the seizures start, they have to be terminated. As they remain untreated, the likelihood of getting a response becomes very less. So the rescue medication should be advised. So that is midazolam, diazepam, and lorazepam. Midazolam nasal spray can be advised if the children is known epileptic, or the parents can give it at home, or emergency response team can use it. These are the doses. However, the efficacy and acceptance of pre-hospital care management of SC is very less. Even in the developed country, about 30% children only receive pre-hospital care. So now coming to the stage 1. So our patient, if we go back, our patient was seizing and he has been to hospital. After receiving diazepam or first dose of lorazepam, he has come to us. So if in the phase 1, which lasts from seizure onset to 5 minutes, what we should do? So first and foremost is assess the child, do a triaging, monitor the vitals, heart rate, oxygen, airway, breathing, circulation, and we should time the seizure. Actually, you have to note when the seizure has started, observe the patient, what is the semiology. Take a good clinical history with the short history, basically, epilepsy and non-anti-seizure medications, fever and rash, and meanwhile establish an IV access. And the drugs which can be given within 5 minutes are benzodiazepine, basically. So if the patient has received pre-hospital medication, 1 dose is usually given. But if it's not received, a second dose can be considered. So either of the 3 can be used, lorazepam, diazepam, and midazolam. And the maximum doses we should take care into our mind. If the excess is not there, then buccal or midazolam or nasal midazolam or rectal diazepam can be given. Meanwhile, the IV access is established. So index case was given lorazepam. He received the second dose, maximum dose 4 milligram, IV access, airway breathing was taken care, and sugar was normal in this patient. So by the time he reached, already 20 minutes has gone. So he's beyond, he's in the second stage and he's having persistent seizure activity. Vitals till now are stable. He's hypoxic and his ongoing seizure shows that he has a low GCS, sluggishly reacting pupil, and signs of raised ICP has started coming, like brisk DTRs, extensor plantar. So now he's into established SC, that is stage 2 of status epilepticus. What should we do in this situation? So again, take care of vitals. If there is a raised ICP, start first line raised ICP measures like head and elevation, minimal stimulation and all. And within 10 minutes, after giving benzodiazepine, assess the response in next 10 minutes. And by the time you should be ready for the second line anti-epileptic agents. So among the second line anti-epileptic agents, there are several of the drugs. So Indian guidelines recommend as a phenytoin as a second line agent, that is 20 milligram per kg and an infusion. Phosphenytoin as an alternative, and if there is no response, a second 10 mg bolus can be given. And however, the recent European guidelines and all, they suggest levetiracetam as a first line agent, and because of safety concern, they have taken IV phenytoin as an alternative. And there is levetiracetam versus phenytoin as coming in the European guidelines. So levetiracetam up to 40 to 60 milligram per kg as an infusion over 10 to 15 minutes can be given. Levetiracetam has advantage that it can be given very fast. However, phenytoin requires a slow infusion and monitoring for the hypotension, cardiac arrhythmia, and skin reaction. So alternative agents are valproate, phenobarbital, and lacosamide. So our Indian guidelines also suggest that after this phenytoin, a second bolus of 10 to total 30 mg can be given. And still, if the seizure are persisting, one of these drugs like second line can also be given, levetiracetam, phenobarb, or valproate. So there are no head-to-head studies to compare efficacy of phenytoin with valproate, phenobarb, but several studies has been conducted to compare efficacy of phenytoin versus phenobarbital, phenytoin versus levetiracetam. So in index case has received phenytoin 800 milligram, no response. Second dose of levetiracetam also is received. Valproate is also received. So you see several the drugs has been given and time has reached to more than 60 minutes. The seizures are ongoing. Patient is low GCS, suspecting a fever history, ceftriaxone, acyclovir, and thiopurine saline has been started in this child. So now we are proceeding towards refractory status epilepticus. So, so as I've discussed, European guidelines are going toward levetiracetam. So this systematic review we have done to compare efficacy and safety of levetiracetam and phenytoin as second-line anti-seizure medication in pediatric SC. So what we, so 11 studies were there and approximately 2,000 children were compared between levetiracetam and phenytoin, both from developed as well as developing countries. The result shows that by 60 minutes, the efficacy of levetiracetam and phenytoin is same. So almost both are efficacies 80%. But the side effects are with phenytoin were high in terms of more number of patients requiring intubation and ventilation, and issues of cardiac suppression was also higher with phenytoin. So the levetiracetam was found to be safer, and hence the levetiracetam is upcoming in the chart in the European countries. So our patient has passed 1 hour, received phenytoin, valproate, and levetiracetam. Seizures are ongoing. Some labs has been sent, which are come back, looks like normal only. He has a little acidosis, which is respiratory and metabolic because of ongoing seizures, and now he's received fluid also, and with ongoing seizures, a diagnosis of refractory status epilepticus is considered. Meanwhile, a CT was done, which appears normal. So now coming to the stage 3 of the status epilepticus, and if the patient do not receive to the first 2 anti-seizure medication, that is 1 benzodiazepine and 1 non-benzodiazepine, then we call it refractory status epilepticus. And if it does not respond or continue beyond 24 hours in presence of anesthetic, it is called super refractory status epilepticus. So in an index case was shifted to PICU, required intubation, mechanical ventilation. He's put on continuous EEG monitoring, and because seizures was ongoing, the next line agents has to be chosen. So midazolam, propofol, thiopentone, and ketamine are the third line agents which are available to us for use. And thiopentone, high dose phenobarbital is one which is upcoming because it's slightly found to be efficacious and because of less side effects. Thiopentone infusion is associated with hemodynamic instability, requirement of mechanical ventilation. And topiramate also found a place here in Indian guidelines because of relatively safer profile in terms of sedation and ventilation, but action of onset is slow in topiramate. So high dose phenobarbital, how we are going to use it? So 5 to 10 ml per kg bolus every 30 minutes, still up to 120 mg per kg. And the endpoint is like you achieve a burst suppression and maintenance is 40 mg per kg. Meanwhile, these are the doses for midazolam, thiopentone, propofol, and topiramate, which can be found in standard text and can be seen there. So by this time, in the stage 3, which is like after 1 hour to 24 hours, workup has to be done, which includes infective workup, CSF, and imaging, HSV, PCR, autoimmune markers, if you do not find any etiology, and genetic and metabolic testing. So if we see the etiology of SC in developing countries, there could be known acute symptomatic like secondary to stroke, hemorrhage, CSVT, or hypoxia, or trauma, or herpes encephalitis and autoimmune encephalitis. Or it could be a known epilepsy, child with known epilepsy who comes with the flurry of seizure, could be malformations, HIE, stroke, etc. Progressive disorder like metabolic and mitochondrial disorder could also be possible. And around 10 to 20% are status are secondary to unknown etiology. So this group is the most kind of recalcitrant who does not respond to anti-epileptic. So 11 to 50% are unknown. These comes into the group of NORS and FIRES. So this is an Indian study which reports clinical profile and short-term outcome pediatric SC. So 60% has acute symptomatic etiology, 30% has previously known epilepsy, and 60% were benzodiazepine responsive. And this is an international study with multicentric cohort. 11% has super refractory status epilepticus. The etiology is like known epilepsy in around 40% cases, fever around infection in 10% cases, So the profile varies in developed versus developing countries, where in developing countries we have more infections and symptomatic seizures rather than unknown etiology, while in developed countries it is more unknown, like 2/3 patients are 22% are unknown etiology. So index patient, again, if we continue, 2.5 hours passed, he's on midazolam infusion. Seizures are reduced but have not stopped, and his investigations still now are on normal because of persisting seizures, started on thiopentone loading 5 mg per kg, mechanical ventilation and infusion. So right now seizure has subsided. It continued for next 24 hours, and once this started tapering, there was a reappearance of seizure. So this is the state of super refractory status epilepticus, where seizure recur on tapering anesthetic agents. So how do we manage a case of refractory or super refractory status epilepticus? So that we'll discuss in the next slide. So first, before that, I'll discuss a brief role of EEG in management of status epilepticus. It is recommended that after 1 hour of SC, status epilepticus, monitoring is required. This could be a conventional 20 channel versus EEGs, which can give you a more information with the shorter windows, like complex spectral arrays or amplitude integrated EEG. In addition, you require NIRS and ICP monitoring can also be done. So these are some examples like how EEG is going to help. First, lesional, it helps to identify pathology. Like if you have focal pathology like PLEDS, a suggestion encephalitis like illness, or this can be seen with stroke and fires also. Ictal rhythm helps in management also. Like once you start them on anesthesia, you desire and bus suppression pattern. So that for that EEG monitoring may be helpful. So this is a kind of a slowing which is seen in a conventional 20 channel EEG. This is an example of short periods of burst suppression, like 1 or 2 seconds. This is like a suppression burst pattern, where is a prolonged period of burst, short burst associated with prolonged period of suppression. These are like delta brushes, which are seen in fires and autoimmune encephalitis. Some kind of ictal rhythm, which is like focal onset and ongoing, can be seen in EEGs, and ongoing ictal rhythms can be seen. This is like example of PLEDS, which gives an idea about a focal pathology. Sometimes this kind of low amplitude EEG is also seen, that suggests a kind of electrocerebral silence. And with the comma inducing agent, our aim is to establish burst suppression. So this is a pattern of burst suppression, but here the suppression is 2 seconds. So we desire around 8 to 10 seconds of suppression when we target a burst suppression pattern. So if a known epilepsy patient is there, then EEG may help you in identifying non-convulsive status epilepticus, where there is a change in EEG pattern from the previous one. MRI is helpful in identifying etiology as well as seizure also lead to MR changes. So vasogenic versus the cytotoxic edema is required to be differentiated. So like you can have some diffusion restrictions in the white matter, or can be hippocampal changes, or there could be stroke or encephalitis. So that's how MRI is going to help you in identifying the etiology. CSF is usually required for basics, cytology, biochemistry, culture, PCRs. And if you think of your scans are normal or show demyelination, then NMO-MOG antibodies and serum autoimmune panels are required. Right now, we are also doing cytokine levels in the CSF, where we do not find any etiology for status epilepticus. So now, so after stage 3, there is a stage 4, where after 24 hours, even with the use of anesthetic agent, seizure tend to reoccur, and you have to give repeated cycles of anesthesia like thiopentone infusion for 24 hours to 48 hours, taper, again seizure recurrence. So then the therapeutic options are limited, but ketogenic diet, immunotherapy, other non drug therapies can also be tried in these cases. So now brief about fires and NORS, because these are the cases which constitute around 11 to 15%, but they are the most difficult one. So NORS is a new onset refractory status epilepticus in childhood, and that is like without any apparent etiology and a previously normal child. And the fires is subcategory where you have a fever preceding the onset of status epilepticus. The fever can be preceding 24 hours to 2 weeks prior to the onset of status, but usually it is not present at the time of onset of fires. So fires can be secondary to viral encephalitis, autoimmune encephalitis, or sometimes it is absolutely not known etiology, like genetic and antibody workup are usually negative for fires. So it's a like of a broad group where you can have refractory and super refractory status, and usually the autoimmune causes are ruled out in these cases, not positive, and usually they do not respond to first line immunotherapy also. So this is a specific epilepsy syndrome in childhood, which begins as a kind of catastrophic status epilepticus and lasts for a few days to weeks to months and lead to subsequently a chronic phase of disability. So usually there is no significant family history or antecedent history. There could be a brief fever followed by a refractory seizures, which could be focal, multifocal, myoclonic, or tonic. And then the seizure tend to subside by 3 to 4 weeks, or sometimes they can take up to 2 to 3 months. And then there is a state of neurological disability where you have vegetative states, drug refractory epilepsy, and lots of sequelae in follow. And MR shows brain atrophy. So in these cases, if you do not find any etiology, like your MR is normal, CSF analysis is negative, and you know that you are dealing with the refractory status or super refractory, then there should be early use of immunomodulatory agent should be there. So steroid and IV methylprednisolone, oral prednisolone, and IVIG is commonly used. So 2 gram per kg IVIG with 5 days pulse is what we are using in case of suspected fires or NOS by day 4 or 5 when we have basic investigation. Plasmapheresis is also like class 4 evidence, not much really effective, but can be used. So recently fires has been found that they can show response to clobazam, phenobarbital. A ketogenic diet should be started by day 7 after the diagnosis of fires, and immunotherapy has a role in potentially reversing these conditions. So anakinra, dexamethasone, and tocilizumab has been used. So over the year we have knowing that these patients are not going to respond to steroids and IVIG. So bring your immunotherapy agents early into the course, like within 7 days you start them on tocilizumab, or after first week when you rule out the most of the conditions, bring on to your newer agents here. So this is the algorithm which was published in 2020, but we have moved ahead with the early introduction of ketogenic diet, IVIG, steroids, and another newer immunotherapy agents in these patients. So some of the newer anti-epileptics have also been found to be effective, like topiramate we found is a good drug, which loading with 5 to 10 mg per kg and maintenance at 10 mg can be lead to seizure suppression. But be cautious about metabolic acidosis because these patients are on diet also. Parampanel, because it's an AMPA agonist, is also a good drug. Lacosamide has also been used as a IV at the level of second tier or third tier. Non-pharmacological measures are diet, vagus nerve stimulation, hypothermia, ECT. So if the targets are achieved, like you have achieved a seizure suppression, maintain the patient on anesthesia for 24 to 48 hours, then start weaning over next 48 hours gradually. If seizure recurrence, then repeat your anesthesia, again give for 48 to 72 hours and give an attempt to trial. Meanwhile, introduce other immunotherapy agents or other drugs. And once you taper, keep them on maintenance therapy with benzodiazepines or barbiturate, or a newer drug like lacosamide, topiramate can be used. So outcomes are usually with status epilepticus, mortality is high. Some around 7 to 40% has been reported. 50% tend to have poor neurological outcome. It persists more than 30 minutes or longer. Younger child, boy, pre-existing epilepsy, failure to respond to benzodiazepine. These are the longer duration of uncontrolled seizure leads to poor prognosis. So use of anesthetic is recommended. However, these children are at risk of ICU related complication and more deaths if they are used. So we have to be like cautious in these patients. Rigorous monitoring is required in these patients. So with this, I end my management of SC here. So I want to say that time is brain, and it has to be early recognized, and early pre-hospital and early treatment has to be initiated. And we know that almost 40% will progress to refractory and 11% to steroid super refractory status epilepticus. And in such situation, there is not much evidence, but you should be knowing that you have to use early immunotherapy in these cases. So FIRES is a distinct epilepsy syndrome, though it is rare, but we do encounter, and these are the most difficult one to treat. And early introduction of diet, immunotherapy, and ketogenic diet can help these patients. So with that, I thank. So time is brain, and the fire in the brain can be extinguished with the cautious use of other than anti-seizure medication like immunotherapy, diet, bringing on to your armamentarium. So that will really help with these patients. Thank you so much. So with that, I'll stop sharing here.
Yeah. I think Renu,
Yes.
it's a
So
very lucid
tried-
presentation.
Thank you, sir.
And I think if I look back at the status management in the last
Right.
40 years, earlier the definition very clearly stated was 30 minutes. Then it
Right.
started coming down with a better understanding of the changes that happen with the prolonged seizure. The management has also considerably improved. In the sense, earlier we used to, now we know the time to the seizures, medication, how it works in the first 5 minutes compared to the next 30 minutes to the next 24 hours. So the whole, because earlier on we had a very few drugs to handle these status, but in the last 2 decades, number of anti-epileptic drugs have significantly increased. But having said that, we had phenobarbital then, dilantin also then, which is still continue to be used in the second stage of the illness. But I think what everybody should understand is the importance of starting treatment as early as possible. Moment it is 3 to 4 and coming to 5 minutes, I think we should be ready with parenteral benzodiazepines.
Right.
Because that is a time when these drugs act on the GABA receptors and help to control the seizures. Once that period is over, then obviously the refractoriness starts. And then we'll have to go to the second line medication, which is obviously the combination of all this phenobarbital, dilantin, levetiracetam, and lacosamide. But what I would like to ask is there any study which is compared head-on levetiracetam to lacosamide?
No, sir, as such, it has just come into the algorithm. There are no head-to-head studies at present. Right now, the focus was to identify optimal second-line agent. For that, levetiracetam was chosen because lots of studies has used it. So in European guidelines, it has come as a second line. But for the lacosamide, right now, we don't have much evidence, sir.
Only there are individual
Yeah.
group of not head-to-head.
No, sir.
I think that has, I think, another important issue that has come more recently is the early use of steroids, immunos, and IVIG plus ketogenic diet and immunomodulators.
Right.
So I think otherwise, any other questions anybody has?
Sir, we can take later on. Because we'll also have the time for the deliberation.
Okay, fine.
Right.
Dr. Paria, please carry participate.
Yes, sir. Thank you, ma'am, for your lucid and elaborate talk regarding status epilepticus. Our next topic is raised ICP to be delivered by Dr. Siddhartha, consultant child neurologist in Royal Institute of Child and Neuroscience in Ahmedabad. He has done his MD, MRCPCH, and CCT from UK. He is the IAP Neurology Fellowship Trainer in India and examiner for MRCPCH in India also. His special interest in neuromuscular and neurogenetic disorder. He had multiple publications and chapters in textbook. Saha sir, for your talk over raised ICP.
Thank you very much for that kind introduction. Thank you very much to the organizers for giving me this opportunity and arranging this very interactive kind of discussion on various topics. So sticking to my topic, basically today we are talking about various neurological issues in ICU and how to deal with them. And quite appropriately, Renu has fantastically covered all the aspects of seizure management or status epilepticus management. So along with that, there is raised intracranial pressure. So status epilepticus and raised ICP, these are two real common clinical conditions that require prompt identification and will require effective treatment to prevent any further secondary brain injury. So let's look at this topic in a little bit more detail. So what are the normal limits of intracranial pressure? So intracranial pressure has different ranges and it depends on the age of a child. So in a term infant, it will range from 1.5 to 6 millimeters of mercury. In a young child, the range is slightly higher, so it's 7 to 10. And as we all probably memorize or remember, the standard range that we know about is 10 to 15 millimeters of mercury, and that is in most older children and even in adults. So what is the target when we are trying to manage raised pressure, or what is the cutoff? What is raised intracranial pressure? So it is widely known that it is safe to keep the pressure below 20 millimeters of mercury, whatever way you are managing it or measuring it. But if you keep it below this level, then it is safe and it prevents any injury to the brain. Along with intracranial pressure, there's another parameter, and that is cerebral perfusion pressure. So what is CPP? That is your mean arterial pressure, that is your mean arterial blood pressure minus the intracranial pressure. So this is the difference that allows the brain to be perfused consistently, and it prevents ischemia and injury to the brain. And the CPP range is usually between 40 to 60 millimeters of mercury. So basically in your multimodal ICU monitoring, when I was in the UK, it was pretty standard that on the screen you will have your heart rate, you will have your SpO2, you will have your blood pressure, but along with that you will have your ICP monitored there, and you will have the CPP calculated there as well. So the formula is already fit in, and along with ICP, the CPP will be calculated. So it is very, very easy looking at the screen to manage that particular patient in terms of raised intracranial pressure. So what are the components of raised intracranial pressure? How is intracranial pressure made of? So as you can see in this cartoon or diagram, that the brain parenchyma volume is about 80% of that. It contributes to 80% of intracranial pressure. Along with the parenchymal volume, there is blood volume, which is about 150 ml. So that's 10% of your total volume. And CSF volume is another 150 ml. So that's another 10%. So this kind of, with this diagram or cartoon, when you're managing intracranial pressure, you will be able to kind of visualize what you are doing and how much effect it has to the intracranial pressure. So the brain parenchyma is about 80%. That's the large part of the intracranial pressure. So what happens when you get an intracranial pathology? So this cartoon shows there's a compensated stage. So this is kind of the starting stage where you have a lesion in the brain parenchyma. So you can have either a tumor or hemorrhage and surrounding edema with it. So when you get this, what happens is there is a shift. So basically via the venous drainage, you get a higher venous drainage. And as a result of that, there is a compensation. So reduction in blood volume. Along with that, there could be higher rate of CSF drainage via the ventricular system. So you have a reduced CSF volume. But this all can fit in. So still in the compensated state, they are all living with each other by changing their respective percentages. And still you are not seeing many signs of intracranial pressure. But as soon as this pathology increases in size, or there is a higher, you could say, this pathology is taking up a higher volume, then there is no way that the brain or the intracranial components can compensate with each other. And so you get a rapid rise in intracranial pressure. So initially, the graph is that you get a slight increase, but gradually, as the pathology starts taking more and more space, then there is no further compensation and there is a rapid rise in intracranial pressure. So this is your decompensated state. And you ideally want to treat the patient or control intracranial pressure before you get to this decompensated state. Why is it so important to control intracranial hypertension, or why is it important to diagnose it early? So as seen in this diagram, there is a primary brain injury. Now the primary brain injury has already happened. So in a way, some of it could be irreversible already before the patient reaches to you or the symptoms appear. As a result of primary brain injury, you get structural and functional changes in the brain. And as a result, you will get cerebral edema. This could be vasogenic, cytotoxic, or mixed. So cerebral edema. So once you get brain injury, you get edema, you then immediately start getting intracranial hypertension and the symptoms related to it. Indirectly, what happens is the intracranial hypertension will then lead to secondary brain injury. So now you've not only got primary brain injury, you've also got secondary brain injury. And along with that, intracranial hypertension will also contribute to ischemia, which again will lead to secondary brain injury. So you're stuck in a cycle. And this is all happening minute by minute inside the brain. So whenever you identify a patient with raised intracranial pressure, your immediate attention should be to try and prevent this further secondary brain injury. So some of the primary brain injury might be reversible, but if you stop having secondary brain injury, then at least it will benefit the patient and it will improve outcomes. So looking at the gross effects of raised intracranial pressure as well, as we all know, the most severe outcome of raised intracranial pressure is herniation. As shown in this cartoon, there are 6 types of herniation, but the common ones that we talk about is downward cerebellar tonsillar herniation. And this cerebellar tonsillar herniation is almost a fatal event. So this needs to be looked after, and you need to identify the signs and symptoms before this happens. Also, along with this, uncal herniation. We talk about this temporal lobe going downwards or herniating, and this is also quite a catastrophic sign. So all these types of herniation need to be prevented when we talk about intracranial pressure. Okay, so having understood the pathologies or the concept of intracranial pressure, how it happens and what it leads to, let's think about clinical causes of raised intracranial pressure. So connected with what I've already said, blood, brain, and CSF. So whenever we see an increase in all these, you will see an increase in intracranial pressure. So venous obstruction, this is mainly in children, we see sinovenous thrombosis or sinovenous obstruction that leads to an increase in back pressure, and eventually it leads to increased intracranial pressure. So along with it, increased blood volume can happen with other kind of phenomenon, and mainly in children, so far clinically that what I see commonly is arteriovenous malformations. So AV malformations can lead to increase in blood volume inside the brain, and if they rupture and cause an hemorrhage and edema, they can also lead to increased blood, intracranial pressure that way. Now talking about brain volume, what can lead to increase in brain volume? So there's brain tumors. Of course, we all know that children can present with brain tumors. Once in a while, we see children either presenting to outpatient or in emergency with brain tumors. Along with that, infections, so abscesses. This could be tuberculous, bacterial, other abscesses, empyema, and intracerebral hemorrhage. So all these pathologies can be seen in children. Now, as I just showed, along with the primary pathology, there could be a cerebral edema, and this could be either cytotoxic or vasogenic or transependymal or osmotic. And as you can see here, a number of pathologies have been listed, which can lead to cerebral edema, and eventually this will all lead to raised intracranial pressure. So what are the clinical signs that we see in children with raised intracranial pressure? And this is very, very important because this will help us in identifying a patient with raised intracranial pressure accurately. So in the history, we often ask about headaches that are chronic and progressive, that are throbbing or bursting in nature. And this is very, very classical, that can be exacerbated by coughing or sneezing, and especially headaches that either wake up the child in the middle of the night or happen in the morning, early morning headaches, as we say. Vomiting that is projectile and it is not relieved by medication. And also another classical sign is after the vomiting, the patient feels a temporary relief in headache or other sign symptoms. And this is a very classical combination of raised intracranial pressure. Along with that, decreased level of consciousness, so drowsiness, coma, reduced GCS, that will of course point towards increased intracranial pressure. Diplopia as a result of sixth nerve palsy, as a long track sign of intracranial pressure. Papilledema. Papilledema is also quite an important ocular sign that can be seen by fundus examination. It's a reliable sign, but the only thing is that it develops after several days of intracranial pressure. It doesn't happen immediately. When you look at pupillary signs, third nerve palsies, again, quite a late sign, so not an early sign, and an ominous sign as well. So has to be identified if present. And then we talk about the Cushing's triad, and this is severe hypertension, bradycardia, and irregular respiration. So hypertension, bradycardia, and irregular respiration is a sign, but again, it's a late and ominous sign of brainstem compression. So probably at this point, you need to really act very quickly, otherwise you are going to lose your patient. So a combination of any of these symptoms and signs will point towards raised intracranial pressure. Okay, so in ICU, how do you measure invasive intracranial pressure? How do you measure intracranial pressure? And there are two ways. There is either invasive or there is non-invasive intracranial pressure monitoring. So non-invasive intracranial pressure monitoring is often done by things like CT scan, MRI, and these can be quite helpful. So CT scan will show hemorrhage or midline shift or cerebral edema, and this will point towards intracranial pressure. MRIs can be more specific, so even things like diffuse axonal injury and edema, especially vasogenic edema, can be picked up quite early on MRI. So these are your non-invasive intracranial pressure monitorings. They won't give you a number. So if you really want to get a number of intracranial intracranial pressure or what the ICP is, you need invasive ICP monitoring. And there are two types to that. In the UK, again, we used very commonly both of these intracranial pressure monitoring methods. In India, we use it a little bit less. One, because of less availability, second, because of cost, and third, because of risk of infection. But the gold standard is intraventricular catheters. And so you put a catheter just like your shunt. So instead of that, you put an intraventricular catheter and you measure global ICP through that. It's transduced and it can be shown as a number on the screen. Along with the benefit of measuring, you can also drain CSF, remove some CSF, and that will help in reduction in ICP. Of course, there's a risk of infection because if you don't handle it properly, you can get retrograde infection inside the brain. Instead of intraventricular catheters, you can also use intraparenchymal catheters. One of the popular one is a Codman rod or Codman angle, and it can be placed surgically and transduced to measure intracranial pressure. It may not represent global ICP because if it's put in one place of the brain and you're getting, very localized raised ICP, or if there are significant midline shifts, you may not get global ICP. But it's easier to place And it is again another popular method of measuring invasive ICP monitoring. Fine. So now we've understood about ICP, we've seen the signs, symptoms, the etiologies, and we've seen how to measure invasively ICP. So how to manage? Now, this is the most important part. I realize that we're running out of time, so I'll try and quickly touch with each of these topics. But it is very, very important to understand this stepwise approach in managing raised ICP. And as shown at the top of the cartoon on your left-hand side, ICP should be kept less than 20 or less than 22, and cerebral perfusion pressure should be kept more than 60 or 70. And this is the target of using any of these treatments. So first of all, sorry, I think the non-invasive slide came now. So as I mentioned already, it's about brain CT, brain MRI, and other methods. I'll skip this one for now. So as I was mentioning, there are many general prophylactic measures. And when should you do these? You should do these immediately. As soon as you identify raised ICP, you've got a patient in ICU, you should start all these measures because they are effective and they are very, very important. Amongst that, intubation and ventilation. So whom to intubate? In comatose patients or GCS less than 8, as we know. Early intubation is very, very important. It helps controlling seizures, it helps controlling agitation, but not only that, it gives you ventilation. So you can avoid hypoxia, hyper and hypocapnia both. If you do too much hypocapnia, that can lead to ischemia. So initially, when you intubate and ventilate the patient, you can bring down the CO2 to bring down the raised ICP. But then eventually, you have to maintain normal capnia, normocapnia, and that will prevent any further brain injury as well. Also, it has been noticed through studies that you should avoid using high PEEP, because if the high PEEP is causing hyperinflation, that will again lead to a significant rise in ICP, and this should be avoided when doing ventilation. Blood pressure and CPP management. Almost all patients with severe traumatic brain injury will have hypotension, either due to the loss of blood or due to indirect mechanisms. But so it is very, very important to identify hypotension, and it is an independent indicator of poor outcomes in patients. So maintain a systolic blood pressure of more than 100 or 110, depending on age as well. Use isotonic fluids, don't use hypotonic fluids. And on the other hand, if you are getting hypertension, start antihypertensive medication if more than 150. Body positioning, very, very simple to do, but we often forget. Keep the head in the midline and head elevation to around 30 degrees. But not more than 45 degrees, because this can again lead to an increase in intracranial pressure. Reduce excessive flexion or rotation of the neck, avoid restrictive neck taping, and minimize stimuli that could cause cough and valsalva, because this will lead to raised intracranial pressure. Temperature control, very, very important. It should not exceed 37 degrees. So we're not talking about fever here, we're talking about temperature control. So anything that can reduce the temperature, intravenous and enteral antipyretic medications, control of room temperature, and cooling blankets or pads will help you in managing the patient temperature. Do not, there have been studies looking at prophylactic hypothermia to improve outcomes, and they do not recommend that because they could not show an improvement in outcomes in these patients, and there were complications as well. What about glycemic control? So hyperglycemia is associated with increased mortality. So the blood glucose should be managed less than 100. And blood glucose should be managed around 100, less than 100 should be avoided, and blood glucose more than 150 should trigger initiation of insulin therapy. What about seizures? Of course, seizure management is very, very important, again, in terms of managing intracranial pressure. So use of prophylactic anti-epileptic treatment for the prevention of severe brain injury was a topic of investigation for many, many years and debates. Now, phenytoin is recommended to decrease the incidence within 7 days of injury. But prophylactic anti-epileptic therapy in other acute neurological conditions other than brain injury is not recommended. What about mannitol and 3% saline? So osmotic agents reduce brain tissue volume by drawing free water out of the brain tissue and into the systemic circulation, where it is eventually excreted by the kidneys. So the beneficial effect of hyperosmolar therapy requires an intact blood-brain barrier. Recommended ICP lowering dose of mannitol, sorry, there's a typo. Usually 20% mannitol is 0.25 to 1 gram per kg every 6 hours, and osmolality should be checked and maintained between 310 and 320. What about hypertonic saline? So bolus doses are usually administered. This is hypertonic saline against measured ICP. And usually you manage the ICP and manage the sodium. So concentrations above normal of 145 to 155 have been shown to give you a good control of raised ICP. Usually the doses we use is 3 to 5 ml per kg of bolus, or alternatively, you can use an infusion of 1 ml per kg per hour. Sedation and analgesia to keep the patient pain-free and to keep the patient settled. So propofol in adults, but not that much in pediatric. We use ketamine nowadays as well, along with fentanyl in PICU. And neuromuscular blocking agents also can be useful in the control of refractory intracranial hypertension. Phenobarbital. Phenobarbital in high doses can be used for status epilepticus or fires and conditions like that. But not only that, it can be used also to control elevated ICP. Steroid use is only indicated for reducing ICP in abscesses or neoplasms associated with vasogenic edema. So steroid use should be limited only to these conditions and should not be used in all conditions of raised ICP. So barbiturates and steroids can be used selectively. What about surgical management? So of course, resection in terms of hemorrhages. So cerebellar hemorrhage, supratentorial hematoma evacuation, or other acceptable indications such as mass lesion of brain abscesses and brain tumors can be surgically resected and will lead to immediate reduction in raised ICP. Decompressive craniectomy is a method that can be used for refractory intracranial pressure. So if you've used all your medical methods, decompressive craniectomy, especially again bifrontal or posteriorly, can be very, very effective. Lastly, another method is CSF drainage. So this can be done again by an EVD or an intraventricular catheter for acute hydrocephalus in terms of if it is secondary to traumatic brain injury or stroke. But except obstructive hydrocephalus, other indications such as diffuse cerebral edema or mass effect due to a SOL, space-occupying lesion, still you can use a CSF drainage via EVD and reduce the pressure significantly in these patients. So this is my last slide, just to summarize. Initially start with general prophylactic measures, then think of hyperosmolar therapy, hyperventilation, therapeutic hypothermia, barbiturates, decompressive craniectomy, and resective and any resective identifiable lesions. Thank you.
Thank you, Siddharth, for that very lucid presentation as usual. I think you have covered through the topic. Only thing is, I think for the purpose of clinical symptomatology, see, this is the raised intracranial pressure normally present in the younger children where the sutures are open. They can accommodate more volume compared to when the sutures are closed. So they can present with enlarging head size because they can accommodate more amount of volume to compensate. As you said, 80% brain, 10% blood and CSF. They can compensate more and they can present without other symptoms. Whereas older children typically present with progressive worsening, headache in terms of severity, frequency, and at the height of headache, they can develop transient neurological deficit related to either cranial nerves or long track. That is when they start coning. They tend to either central or uncal or medullary coning. I think that is important recognition. And I think then you highlighted very well the pathophysiology, how the the compensation occurs initially and then the secondary effect due to vascular. But in pediatric practice, as far as hyperosmolar solutions are concerned, you prefer mannitol or do you prefer saline?
Yes, so I think this debate has been going on for a while, and now I feel in most of our PICUs or surgical units, 3% saline has taken over now. So mannitol is being more and more is being used less, and 3% is being used more now. Especially given the advantage that you can even use it as a continuous infusion for up to 12 or 24 hours.
Exactly. Another one is, do you think Diamox as a acetazolamide has a place in chronic raised intracranial pressure?
It does. I mean, it has a weak effect. So yes, so the most patients that I use it is after cerebral sinovenous thrombosis. So for many months, they have a kind of low-grade raised intracranial pressure, and Diamox can be used for that. The other indication is often craniosynostosis. So in craniosynostosis, again, you can give it to outpatient department patients and they can take it for a number of months before they have their surgery or further management.
I think the other word is people should be very clear in terms of the kind of edema that you see in a particular pathology. Like all perilesional edemas are vasogenic, whereas others are more cytotoxic in trauma and HIE, or interstitial edema when it is a pressure on the CSF. So appropriate agents has to be used, because I've seen indiscriminate use of steroids when there is no specific, unless you know what is the kind of edema that you have. If you're looking peritumoral or pericysticercal or perituberculoma, then there is a definite role where vasogenic edema is the predominant clinical picture. But whereas in the rest of them, like in hydrocephalus, where there is a lot of interstitial edema, or when there is a cytotoxic edema, I think the role is. Hello? What happened? Am I audible?
Yes.
Yes, yes.
Hello?
Yes, sir, you are audible, sir.
So I think he has highlighted very well on the pathophysiology and management. So I think with that, I think we can go to the next speaker.
Yes. Dr.
Thank you, sir. Thank you, Arun sir, and thank you for lucid presentation and lucid and elaborate presentation, and Dr. Shah. Our next speaker is Jayasankar Kaushik, additional professor and head of the Department of Pediatrics, AIMS Guwahati. He had done his MD and DNB in pediatrics and DM in pediatrics from New Delhi. He was awarded with Balagopal Sadu Endowment Award in Child Health from IAP in 2008. Career interest is pediatric neurology and medical education. Topic of discussion is basic approach to childhood acute ischemic stroke. Kaushik sir, direct to you.
Thank you, Dr. Pradeep, and I thank the organizers for giving this opportunity to interact in this platform. I think it's almost midnight and all of you are quite sleepy. So let's just quickly go through this presentation, a short presentation on an approach to pediatric arterial ischemic stroke. And we know that it is practically not possible to cover pediatric arterial ischemic stroke in a short minute. So the main objective of the presentation will be to recognize the stroke early in the emergency settings and differentiate it from the stroke mimics, and to correctly classify and initiate the treatment among children with arterial ischemic stroke. So we know that stroke is something which is usually defined as something which is rapidly developing sign of a focal or a global disturbance of cerebral function, which is lasting for more than 24 hours with no apparent cause other than that of the vascular origin. So the three key terms that we usually use in Pediatric stroke is something which is rapidly developing, lasting for more than 24 hours, and which is of a clear-cut vascular origin. And we know that the incidence is almost like 1 to 6 per a lakh children per year. And we broadly know that there are two types of strokes. One is broadly the ischemic strokes, which can be arterial ischemic strokes or venous thrombotic strokes, or we can also have hemorrhagic strokes. Now, the arterial ischemic strokes are the ischemia which is conforming to any particular arterial vascular distribution. So, depending upon at what age it usually presents, we broadly divide it into neonatal strokes and childhood arterial ischemic strokes. Neonatal strokes are usually classified in a different manner because they usually have a presumed prenatal stroke, and childhood arterial strokes are usually presenting with a sudden onset of a hemiparesis. Now, when we start looking at the clinical picture of the children, we know that the arterial strokes usually have a very insidious onset, and they will usually present to us with a focal weakness, speech disturbance, or an ataxia. Whereas in hemorrhagic stroke is something which will have a very sudden onset. It's a stroke or a focal neurological deficit that develops within hours or minutes of presentation. And in contrast, embolic strokes are rather hyperacute in onset per se. So what is the type of the onset, we can differentiate whether they are arterial, hemorrhagic, or an embolic stroke. And most of the younger children have a non-specific presentation of the stroke, like seizures, altered sensorium, and irritability, rather than older children who usually present to us with focal deficits like hemiparesis, sensory disturbances, speech disturbances, visual field defects, oculomotor palsies, headache, and vomiting. So focal neurological deficits are usually the classical presentation in the older children, whereas younger children usually have a very non-specific presentation, just like a seizure or an altered sensorium. And at times it becomes very challenging to just consider arterial strokes on the basis of only the clinical presentation. We all remember from our anatomy that this is the circle of the Willis with the circulation which is there, and we know that there are broad vascular territories which can be affected. So as in this case, you can see that the lenticulostriate branch of the middle cerebral artery is getting affected. Here the entire left MCA and PCA is getting affected. Here it is the right posterior cerebral artery that's getting affected. Here it is only the left anterior cerebral artery that is getting affected. So these are the type of the stroke which are restricted to one particular arterial distribution per se. So similarly, you could also have cortical branches getting involved, only the inferior division getting affected, only the superior division getting affected, or you can have also watershed kind of infarcts which can also be seen. So broadly speaking, arterial ischemic strokes can have a varied kind of a presentation. Now, when we look at the etiology is a very, very broad list of vasculopathies, prothrombotic states, cardiac, metabolic, and hematological causes. But predominantly, when you see the pediatric strokes, it is the vasculopathy. And out of these vasculopathy, it is the focal cerebral arteriopathy, moya disease. These are the two important causes of vasculopathies that we need to consider. But in addition, yes, prothrombotic states are also very, very important cause of pediatric arterial ischemic strokes per se. Now, when we are looking at the arteriopathy, in the arterial ischemic stroke, the most common risk factor for the recurrence is arteriopathy per se. And one of the most common arteriopathy that we tend to see is the post-infective, or what we call it as a focal cerebral arteriopathy, which is usually presenting with an acquired unilateral monophasic intracranial arteriopathy, which is associated with a basal ganglia stroke. And we know that typically it involves the distal internal carotid artery with proximal anterior cerebral artery and middle cerebral artery. And one of the characteristic feature of the focal cerebral arteriopathy is that it is usually not a progressive condition. Whatever happens is one time insult, the things usually improve over a period of the time. And it is often considered to have an inflammatory or a post-infective kind of a presentation. Many of these children will have some kind of a URI or some kind of an infection 1 week prior to the onset of the illness. So when you know that a child presented to us with a focal neurological deficit with a preceding history of the fever, we often consider a possibility of focal cerebral arteriopathy per se, because in the follow-up, most of these children tend to improve. But yes, the deficit, which is usually a basal ganglia stroke, can often be persisting. Now, in the second type of the arteriopathy, the first one was focal cerebral arteriopathy. The second one was moya-moya disease, and we know that moya-moya has a very strong genetic basis, and they are usually bilateral and progressive, and they are progressive as compared to non-progressive focal cerebral arteriopathy. So again, here also you have stenosis or occlusion of intracranial internal carotid involving the anterior and middle cerebral artery. And we usually say that we call it as a definitive moya-moya disease when there is a stenosis of the terminal ICA, proximal ACA, MCA, and when it is bilateral with abnormal vascular networking that starts happening in the basal ganglia. So what we are trying to look at is that whenever we are having a bilateral and a progressive kind of a stenosis, we often think of a moya-moya disease. But yes, these are very, very important to know that moya-moya can also have a unilateral kind of a presentation with collaterals can be there and collaterals may or may not have developed. So these are some of the typical radiological signs like IV sign and moya-moya disease, which is very, very commonly encountered and which makes the radiologist think that yes, probably we are dealing with a moya-moya disease. The third type of the vasculopathy, apart from the focal cerebral arteriopathy and moya-moya disease, is arterial dissection. Fortunately, we don't see too much of arterial dissection, and we need to remember that the CTA is CT angiography is something which is far more superior to MR angiography in detection of arterial dissections and aneurysms per se. Now, the fourth type of the vasculopathy, which is also not a very, very common condition that we encounter in the practice, but yes, we need to consider CNS vasculitis, especially if a child has presented to us with newly acquired focal or a diffuse neurological deficit or a psychiatric manifestation, including regression in a previously healthy child. So if the child was absolutely fine and the child has had a cognitive regression and you get this kind of an MRI picture where you have diffuse, bilateral, asymmetrical, white patchy lesions, we often consider CNS vasculitis as one of them. And we know that there are three broad categories. It can be non-progressive, large medium vessel involvement. It can be progressive, large medium vessel involvement, or it can be a small vessel kind of an involvement also. And apart from the vasculopathy, which is a big chunk of pediatric stroke, we know that cardiac diseases are one of the important factors. Similarly, we also have coagulopathies. We have sickle cell anemia, iron deficiency anemia as some of the important factor. And we need to also remember that prothrombotic conditions are often associated with many of the vasculopathies also. So prothrombotic workup is often required even if you are able to determine any kind of a etiology per se. Now, in children, when you look at it, you have a very broad list of stroke mimickers, because every time a child presents to me with a focal neurological deficit, I don't start thinking of a stroke immediately. I think of more common causes like NCC, tuberculomas, Todd's palsies, and press kind of conditions. So these are very, very common conditions that we encounter. And this is one big list of stroke mimickers which are there in pediatrics that makes our clinical diagnosis just on the basis of clinical suspicion becomes a little very tricky. Now, in addition, when we look at the radio imaging can also be a very tricky thing, because the CT scan can be normal within 24 hours. And in many of and then many of the time, the CT scan is something which is only useful for, differentiating hemorrhagic stroke, mass effects, and CTVS, cerebrovenous sinus thrombosis, where you can see the dense cord sign, you can see the dense MCA sign, which is usually seen, and you can also see subtle signs of vascular stroke, which can be seen. But again, we know that because of the radiation risk, CT scan is not something which is the investigation of the choice per se. But few things that we need to remember in recognizing when we are looking at the stroke is the CT fogging effect, which we should always keep in the mind, and hemorrhagic transformations. These are two important things which can often give us a little googly, in the form that the CT fogging effect will be hypodense infarcted area which was there can totally become isodense owing to resolution of the edema between 2 weeks to 6 weeks. So when we repeated imaging 2 to 6 weeks beyond the insult, many of the time the CT can often be normal. Similarly, the arterial ischemic stroke, 15 to 20% of them will undergo hemorrhagic transformation. And because of the hemorrhagic transformation, many of the time we start thinking that could it be a could it be a venous stroke, or it could be a hemorrhagic stroke, but they are usually the hemorrhagic transformations of the arterial ischemic strokes that we need to recognize. MRI always remains the gold standard of the diagnosis, and we all know that DWI images and ADC map are very, very useful. And in addition, we are also very important thing that you need to remember is that the T2 images give you a lot of information in the terms of loss of gray matter, white matter junction, sulcal effacement. All these things can be seen, and many of the time the perfusion mismatch can often be also detected, and MR angiography is a very useful addition to the for recognizing the strokes. So when we are looking at the evolution of the arterial stroke into 6 hours, and in 30 hours you can see that it is a big stroke, and then it becomes a subacute infarct, and the same area becomes gliotic when it becomes a chronic kind of infarct. So every time it is not the DWI which is going to give you every kind of a picture. It is a spectrum at what time you're getting the neuroimaging after the stroke is also very important. So similarly, when you're getting a neuroimaging quite early into the illness, diffusion perfusion mismatch can also be very useful to give you a little bit of information. Now, the stroke workup is something which is known to most of you, and you all know that echocardiography, serum homocysteine level, electrophoresis, thrombophilia workup, they should always be these are a long list of the stroke workup that we usually conduct. But just remember one point, that the thrombophilia workup should be conducted even if you are getting some kind of other obvious causes also. So the main treatment to stay is always supportive kind of a treatment, where we know where the previous speakers have very clearly pointed out on maintenance of normothermia, euvolemia, control of systemic hypertension per se, and role of continuous EEG monitoring, and a long discussion on management of raised ICP was already taken by previous speaker. Now, a thrombolytic therapy, as far as thrombolytic therapy is concerned, there are very limited to case reports, case series, tip studies. Most of them have not given a very clear-cut conclusive evidence for use of these thrombolytic therapies, especially in children less than 5 years of age. So per se, unless and until there are additional published safety data, TPA is usually not recommended for arterial ischemic stroke outside the clinical trials. So let's just quickly look at few cases which we often encounter. This is an 11-year-old boy who presented with right-sided extrapyramidal dyskinesias, altered sensorium. Stroke workup was completely normal. You see that there is an infarct which is there in the left PCA territory. Per se, and you can very clearly see that the angiography also reveals the same thing that is absent. And after 6 months, when you see, the things are probably improving. So that means this was an infarct, and the MR angiography is improving after some point of time. So it's a non-progressive vasculopathy. So it's a non-progressive focal cerebral arteriopathy. But since it is involving posterior circulation, we are calling it as posterior circulation kind of an infarct. Now, few points that we as a clinician should always remember is that whenever we are having an arterial strokes, especially when it is, extracranial arterial dissection, or if you are having a cardioembolic kind of a stroke or a cerebral venous sinus thrombosis, these are the three major indications for anticoagulants to be started. Especially these anticoagulants like low molecular weight heparin can also be considered for the initial 5 to 7 days till you're trying to rule out cardioembolic, and dissections are fairly excluded. Remember that if it is a vasculopathy, including post-varicose angiopathy, or if it is an idiopathic stroke, it is the antiplatelet drugs that are very important. So that means if you're getting cardioembolic stroke or a venous sinus thrombosis, it is anticoagulant like low molecular weight heparin. Whereas if it is a vasculopathy, it is the aspirin that is very, very important. You can consider starting low molecular weight heparin for the initial few days till you're trying to rule out cardioembolic and dissection has been completely ruled out per se. So remember that if there is a CNS vasculitis, immunosuppressive therapies can also be very useful. So this is another 10-year-old boy with right-sided focal seizure, right-sided hemiparesis. You can see that there are multiple collaterals which can be seen. This is very classical moya disease in which the child presents to you with a focal seizure and a right-sided kind of an hemiparesis. So in such condition, again, it's a vasculopathy. Aspirin needs to be started and involve the pediatric neurosurgeon as fast as possible into the picture. So this is a 12-year-old boy who presented with headache, neck stiffness, and right-sided hemiparesis. You can see a very nice hemorrhagic kind of a stroke which is there, and you can know that this is probably an AV malformation that has led to an intraparenchymal hemorrhage. So you need to know that these are the conditions which will require DSA, digital subtraction angiography per se. So this is another case of a 4-year-old boy presented with altered sensorium following refractory seizures that lasted for 4 hours, no preceding fever. So in such a condition, you can see that this is like a cerebellum that's a little whiter as compared to the entire cerebrum. So this is often called white cerebellar sign, and you can see a global hypoxic damage of the entire cerebrum which is seen. So this is also often very, very commonly seen, especially following, refractory status epilepticus in an Indian setting. So it becomes very important that you are not you're treating the status epilepticus as fast as possible so that this kind of an end result often does not happen. Now, this is another case of a 4-year-old male who presented with seizure followed by visual disturbance that resolved within the next 3 days, something which is very clearly resolving in a very short period of the time, presenting with some kind of a focal deficit like vision defect. You know that this is a kind of a condition which is posterior reversible leukoencephalopathy or a PRESS kind of a syndrome. Now, another case of a 3.5-month boy who presented with sudden onset of inability to move the left upper limb and lower limb following a trivial fall from the bed. You can see mineralizing kind of an angiopathy which can be seen in cerebral vessels, which often result in similar post-trivial trauma kind of a mineralizing angiopathy presenting to you with a stroke kind of a manifestation. So this is another spectrum of a 4-year-old boy who presented with seizure followed by right-sided hemiparesis. So if a child presents to me with a right-sided hemiparesis seizure, will I always consider stroke, especially if it is resolved within next 3 days? Rather, the MRI is totally normal. So this is probably a TOTS kind of a palsy. So we need to remember that everything that presents to you with a focal neurological deficit in an emergency setting is not a stroke, and many of the time neuroimaging gets little delayed, and neuroimaging is the important point to recognize arterial ischemic stroke. So this is another 10-year-old boy who presented with sudden onset of severe headache with weakness of the right side of the body. If somebody presented like this, I get a neuroimaging and I see that this is likely to be an NCC. So every time we need to remember that pediatric strokes do not classically just present with hemiparesis. So hemiparesis, there is a big list of stroke mimickers that we need to remember. So the important take-home messages that I wanted to give was that the stroke can be involving arterial ischemic stroke, can be a childhood kind of a stroke. It can be a perinatal stroke that starts right before 28 days of life. You know that the risk factors are very many: cyanotic congenital heart disease, dissection, CVST, hemorrhagic stroke. But we need to remember that majority of them are because of an arteriopathy. The most important challenge that we face as a clinician is that there is a long list of non-vascular etiology for a child who presents to me with a focal neurological deficit. So every time a child presents to me with a focal neurological deficit, I will not think of a stroke immediately. Rather, I will start thinking of more important stroke mimicker like TOTS, NCC, ADEM, rather than coming into a clear picture that this is probably stroke. But getting a neuroimaging in a small child is also a very, very big challenge. So these important challenges in terms of large list of stroke mimickers and difficulty in getting neuroimaging, these are some of the important reasons why the pediatric stroke gets recognized quite late as compared to the adults which are there. And the most worst part is that they have a very, very varied kind of a presentation. Unlike adult, somebody who presents to me with a sudden onset of a hemiparesis, you start thinking it is stroke. But children often do not present. They just present with very, very vague symptoms like crying, irritability, movement disorder, vision loss, seizures, altered sensorium. So very heterogeneous kind of a presentation of the vascular stroke that we tend to see. So the quick revision is that if a child presents to me with arterial ischemic stroke, non-moya-moya vasculopathy, you know that aspirin is often the drug of choice. If it is moya-moya vasculopathy, it is revascularization. Until surgery, aspirin is very useful. If it is an extracranial arterial dissection, low molecular weight heparin is very useful. If it is an arterial stroke with a cardioembolic phenomena, you need to give low molecular weight heparin till the corrective surgery is usually done. In venous sinus thrombosis with or without hemorrhagic transformation, it is the low molecular weight which is usually useful. And in hemorrhagic intraparenchymal bleed, DSA is something which is very useful for therapeutic point of a picture. So to just sum up, recognizing and considering stroke in a focal neurological deficit in any child with or without altered sensorium becomes very important. It's essential to identify underlying vasculopathies like focal cerebral arteriopathy, moya-moya disease, dissections, aneurysms, AV malformation, and the goals of management will ultimately remain to optimize the recovery, prevent recurrence, avoid complication, including those of unnecessary and potential harmful intervention. So with this, I thank the organizers for giving this opportunity to interact with the audience. Thank you. Thank you.
Very short period, you have covered the entire vascular. I think a few words. One is regarding the perinatal stroke, where I think specifically you should look for hypercoagulable states, which I think like factor V or prothrombin mutations and deficiency of protein C and S. These kind of workup need to be done. Other important issue which is recently not been picked up is this primary arteritis of the CNS, what we call it as a PACNS, where the importance of early diagnosis, because unless you do a specific investigation like angiogram or a biopsy or a CSF analysis, you may miss the diagnosis of the primary arteritis of the CNS, because where there is a definite role for giving alternative medications, like including apart from steroids, even cyclophosphamide, azathioprine, and mycophenolate. All these have been tried in various series. I think these are the two which have been recently, it has been there earlier, but has been recognized more now with the invent of MR angio and specific arterial studies. And I think except for that, I think you have covered most of the part of vasculopathies. And I think it's a lovely presentation.
Thank you, sir. Thank you.
Yes, Dr. Pradeep.
Thank you, sir. Thank you, Kaushik sir, for your present and elaborate presentation. Actually, we are ahead, or we are crossed our time limit from 10:30, near about 20 minutes ahead from 10:30. I just like to hand over to Arun sir and Kiran sir for concluding remarks.
Yes, so thank you very much for today's session, Dr. Pradeep. You have wonderfully covered all the aspects of the ICU neurology regarding the pediatric practice, and particularly our chairperson, sir, Dr. Arun sir, who has given wonderful comments as well as given insight in all the topics and motivated our speakers. And our speakers are wonderful and they are so exhaustive and elaborative in their presentation. And they have covered so many things within a limited period of time. Definitely, our audience have got benefited by all the topics. So with this, I close the session as Dr. Kalpana ma'am is in the flight, so she will be not joining for the further proceedings. So I am closing this today's session. Thank you very much, and as well as the DIP who has given the extra time for our today's session. Thank you each and everyone.
Thank
You,
you
sir.
all speakers.
Thank you.
Thank you, Kiran.
Thank
Thank you,
you.
Arun
Thank
sir.
you.
Yeah,
Thank
Thank
you.
you.
thank you.
Thank you, sir.
Thank
Good night.
you.
Okay, then, Kiran. Good night to all of you.
Good night.
Good night,
Good
sir.
night.